impact of the suboptimal use of diagnostics have on the wider health economy, and how do we think about designing and contracting for effectiveness rather than efficiency? So this all started about 5 years ago. I noticed in the lab that we had a doubling of urine specimen testing for culture in the previous 10 years. And this is quite expensive. It's about an additional £100,000 of test costing to the CCG. And that was really unmanaged growth. But from a clinician's point of view, it's about medicine leading to unnecessary prescription of antibiotics. And when we looked narrowly at why this was happening, we saw a combination of inconsistent guidance, incomplete understanding, and all driven by non-clinical processes. So we did quite a lot of work on on rectifying some of those issues. And what we saw, that by focusing on what matters to patients, which is can you diagnose my urinary tract infection properly, we could get a sustained reduction in unnecessary testing. So moving from about 2,500 tests per month peak in 2010 down to around 1,000 now. That's a reduction in costs of £300,000 over 2 years across North Devon, and obviously that speaks to managers, but doesn't speak to clinicians. What got the clinicians on board with all of this work was the fact that we impacted on workload, and that is a currency that is well understood by clinicians on the ground. There's quite a lot of learning came out of that work, but the main one being that the leverage for improvement is not in the lab, it's outside the lab, and looking at areas how we actually use tests in the first place, and then how we act upon tests. And thinking about this in terms of how Vanguard would describe it, it's a move from inside-out thinking, did I do my bit well or according to specification, to outside-in thinking, did we deliver what the patient needs. And our hypothesis is that it's possible to derive a quality policy that leads us towards purpose. And so for this is the test must come into the lab clean, they must pass through the lab clean, and they must leave the lab clean. And we'll talk a bit more about that as we go through the talk. But we also notice here that accreditation is an important system condition which drives some of this inside-out thinking and that we need to tackle. There's quite a lot of similarities here with medicines optimisation. This is where we joined up with Richard Croker. Both of these have been described, so pathology and medicine, as golden threads running through healthcare. And similarities in that drugs and tests are usually delivered from a separate clinical provider, so that's either the laboratory or the pharmacy. The optimal use of drugs and tests is complex, and both services are under considerable scrutiny to save money by reducing costs. Think about end-to-end effectiveness and how we deliver that. For the pharmacy, clean is essentially getting the right drug choice. Clean through for them is that the drug is correctly dispensed, and clean out is that the drug is correctly taken by the patient, and the patient has a good patient outcome. If we mirror that in the lab, the clean in is what we would call the pre-analytical phase, clean through is the analytical phase, and clean out is the post-analytical phase. So we're going to talk about liver function tests. This is the last thing we've looked at in detail, and a particular liver function test called the ALT. So, to give us a sense of scale here, the percentage of citizens of North Devon who had their ALT measured last year, we're talking 25% of the population. The percentage of those that are abnormal, and for the non-pathologists in the audience, abnormal means anything that falls outside a reference range. That doesn't mean that it's necessarily pathological. But 10% of all of those ALTs are abnormal. And the question is, what happens to those patients? So to find that out, you have to go and sort them. So here's an example of what happened. So we've got a 76-year-old man who had a history of leukemia, which is now in remission, had been for about 5 years, and transient ischemic attacks. He'd been on a statin for secondary prevention for about 6 years. And we saw him because he covered some blood tests, because his liver function test had been checked. The previous chronic vascular disease review had been found to be raised. So the GP undertook further blood tests, so it's still abnormal, and reduced the statin. And all of this led to 14 GP interactions in the previous 12 months, all related to this abnormal test. The GP had assumed that the abnormal test was due to the statin, and so they reduced it. Probably incorrectly, so those that now would have little efficacy. What is most noticeable though is the effect on the patient, who a year before had been reasonably also knows that he gets a degree of false reassurance from this. So he thinks that the tests are checking for all sorts of things which they're not checking for, particularly things like relapse with leukemia. The blood test would not show up things like that. But if you look at it from our perspective, or inside that lab perspective, then everything we did was technically correct. If you look at it from what matters to the patient, they'll say things like, I want to feel cared for by people I can trust. I want to know my care is correct for me. I want to know if I'm normal. And if I'm not normal, I want to know what I need to do to rectify that. If you look at it from that perspective, then we didn't do so well. And these are the basics, and these are the foundations, I guess, of the service that we're now trying to rebuild. So if we look at it from a clean-in perspective, so the first thing to note is that LFTs are not necessary in this situation. They only need to be checked 3 months and 12 months after starting the statin, not every year for 6 years. The patient's not consented. The patient doesn't understand what tests have been done and why they're being done, leaving potential for misunderstanding about what we've done. Is it clean through? So what happens in the lab? Well, yes, we've got the results out by the time they needed to be seen, and they were probably highly accurate. Was it clean out? Well, not really. The test results never reflected what was normal for that patient. The GP, everything outside a reference range was flared and needs action. And the results certainly don't help anyone decide on the next step. So designing a pathology optimisation service, what we realised from stories like this is that the lever for change here is around delivering better effectiveness from pathology, and we mirrored the medicines optimisation service, which has had great success over the last decade. And this has 3 tenets really. So the clinical effectiveness side, which is doing the best care that, or delivering care that will deliver optimal outcomes for patients. But to do that, you also need to understand variation and you need engagement with all stakeholders. So we set up a team which includes outside-in focus biomedical scientists, with people that would normally be stuck in the lab doing tests, but now getting them to go out to the clinical coalface and start seeing patients and interacting with clinicians. We've got clinical leads, we've got link clinicians throughout primary care, and we put in external stakeholders when we need them. We have half-day peer-to-peer meetings, and we go out to practices to talk with them about issues that they're having. So some of the things we've done specifically around ALT, we've brought in evidence-based point of view order sets, which are delivered through electronic ordering. And we did a lot of work on not just dropping that into practice, but doing work on helping them implement it. And this is the effect on their weekly ALT requesting in North Devon. So you can see that the line there is 2012 control limit, and we're starting to push the systems. We introduced this about the beginning of 2015, and you can see the effect there on the right-hand side of the graph on the weekly ALTs. This isn't a uniform across all practices at the moment, so if we look at practices that have fully implemented this system, we see a much more dramatic effect. So one practice here has pushed their ALT requesting back to around 2004 levels since introducing the order sets. So this is a very standard practice that will be, you'll have many of them in your region. If you extrapolate the savings that practice has made, that would equate to about £9 million across the country, just in dealing with better testing for chronic diseases. We also identified some practices may need some support. This is quite a large practice that we know has had difficulty in implementing some of this guidance before, and you can see that they haven't apparently managed to introduce order sets, so we need to go do some work with them. Also, data provides assurance it's clinically safe, so this is ALT got 120, so this is moving into areas where we, as clinicians, we would be getting a little bit worried. That's quite a high level. And what we see is that by bringing in this guidance, we haven't actually impacted on picking up the clinically important findings. But I think what's perhaps most important to us is that by focusing on what is important to patients, we have a significant impact on heart and reducing system costs. So So we see reduced anxiety and time taken for patients who come to practice, go to appointments. We see reduced use of follow-on tests. We see reduced follow-on investigations, so we think that we have reduced gastroenterology referrals by probably up to £100,000 across the region, with probably impacts on different ultrasounds, but that is quite difficult to get the data to prove that at the moment. So the important thing for GPs and nurses certainly is the effect on their workload. So each one of these tests, if it's abnormal, will cause work to be done, and we can avoid that. So where do we see the future of pathology on the basis of this work? So we feel that the biggest opportunity is not one of efficiency, it's one of effectiveness. And I guess what we think we have shown is that it's possible to redesign services to make this shift. And for us, that's an optimization team driving service improvement and redesign, and by thinking about how they use measures derived from purpose and what matters to inform our method. Two significant barriers to sustainable change. First one is around how we provide meaningful assurance and our accreditation agencies up to the task. And the big one is how we can track all of this. We're starting to make some progress in moving away from activity-based contracts, but to actually contract for effectiveness is, I think, an ongoing challenge for the NHS. And that's the end of that talk. Is there any questions? Any questions? Are you still there?
We are.
I can't see your pictures anymore. Have you got our video then?
Yeah, we can see you.
We can see you, yeah.
Alright, I thought I could just see if it looks like there's been some sort of nuclear holocaust in Brighton. So that's quite pathology specific, some of those things, but I think the concepts of how we go about understanding how our services work and how we organise our services according to what's important to patients or our clients is universal, I think. And I guess this work done with Vanguard, I think the Vanguard consultants instantly identified problems really within about 2 minutes of sitting down in a clinic with us. So these are universal issues in healthcare, I think. Who's there? Hello. Do you want to move on to Darren's talk about wound care as a more specific example?
Yeah, great.
Oh, come on.
Hello, I'm Darren Whiteley and I'm a GP, and I've been working with Tom as part of the pathology optimisation team, and also Richard Croker with medicines optimisation, and I guess we've been working together over the last 4 years or so, and because testing crosses 80% of all pathways, we found that what we've ended up doing is improving lots of different pathways which run through different tests, but often the improvement that we've done has been around the surrounding services to ensure that the test is actually being done appropriately. So I'm going to talk about lower leg wound care and try and do this talk on the way that we would approach to studying a problem, whatever problem that might be, and the concept that we use for this test and this pathway applies to all of the work that we've done really. So we first identified that there was a problem from the inside out. So we refer to inside out as this is what we are seeing as organisations working in our own silos. And we all saw quite different things depending on what kind of primary that we're in, but all of us were kind of saying things weren't quite right. So the lab was the first to identify that there was a problem. So there seemed to be too many wound swabs being sent to the microbiology lab, which seems to be of low value. And these seem to be coming from these chronic leg wounds, which would turn into chronic leg ulcers. And it seemed that lots of patients were getting repeatedly swabbed and having repeated antibiotics, Viability are an interstate service that works between primary care and secondary care. They were seeing problems in secondary care that they really felt should be dealt with quite easily in primary care. We in primary care, in turn, felt that we weren't really being supported enough and weren't getting enough tissue viability input. And also in secondary care, there was probably we have high amputation rates in North Devon. I don't really know why, but the feeling was that maybe the presentations from primary care were a bit late. And again, as tissue viability was saying, that maybe if we were doing things a bit better in primary care, that amputation rates and late presentations wouldn't happen that often. And also in primary care, we were finding that we had a high workload from these wound dressings, and there were grumblings that it was taking up too much time and that we were overworked. And at that point, primary care was thinking about, particularly in my practice, skill mixing, so seeing whether HCAs could do dressings instead of the nurses. So that was how we saw the problem, but that was very much from an inside out. That was from our perspective as people working in the healthcare system. So using this method, really, we started off saying, well, we're identifying the problem from the inside, but what is the problem from the outside, from a patient's point of view? And what is it that matters to patients? So we very quickly found that what mattered to them was, I would like my leg wound to heal quickly. So to study this problem, we went out to study demand, so what was happening out there with patients. There was a multidisciplinary team, which I think is necessary really to get the different perspectives about the patient's problems from different points of view. So we had a GP lead, practice nurse, tissue viability, Tom from the microbiology lab, and vascular surgeon input. And we interviewed patients, and we also did an audit looking at patient stories in primary care. And our main finding really was that the wounds were taking too long to heal. So going back to what matters and finding that the wounds were taking too long to heal, we then, as a multidisciplinary group, studied the conditions together. And again, I think this was very beneficial in the fact that each of us knew what we were doing in our part of the system, but to bring it together as a whole, to really understand it, needed 5 people to put their heads together and be quite open to what was happening and open to learning. So we identified that the root cause of the wounds not healing was that we weren't finding out whether they were venous wounds or arterial wounds as a root cause for them not healing. And the only way to know this really is to do something called an ankle brachial pressure index, an ABPI, which shows how much blood is flowing down the leg. What we found was that this is necessary, should be done very early, within a couple of weeks of the wound presenting, but it wasn't being done because it takes about 20 to 30 minutes to do, and primary care nurses were overworked. So this was leading to a lot of quick fixes. So instead of trying to identify the root cause, we wanted to do an ABPI because that takes too long. A very quick and easy thing to do in a 10-minute appointment for a wound dressing is to just say, well, this wound isn't really healing. Why? Maybe it's infected, it looks a bit red and fluffy. Let's take a swab and see if it's infected. So that's what we saw time and time again. Lots of swabs being taken, often repeatedly, leading to antibiotics, which probably weren't indicated because wounds will have some bacteria in them anyway. So not only the problem of lots of the cost of the wound swabs going into the lab, lots of antibiotics for the patient and the harm associated with that, and the wounds weren't healing. And really it was because not enough time was invested up front to take the 20 to 30 minutes to do the ABPI. And also contributing to this was a lack of continuity in nursing staff, so there's always a different nurse every week, and each nurse didn't quite know where the other nurse had got to in the previous week, and whether they'd done an ABPI or not, so they just kept on dressing it and taking swabs and dressing it, and pushing forward the patient's care for the next week. And so, studying what was happening, we found that a lack of ABPI, which really is a key intervention here, was leading to a lot of failure demands. So, because we weren't finding out the root cause of the wounds, the average length of heal rate for wounds in my practice was 12 months, which is just terrible really. 80% should heal within 3 months. So this was generating 9 months of workload for practice nurses and considerable morbidity for the patients, which were coming up twice a week to get their legs dressed, and it just wasn't healing. The daily demand was that, again, the wound swabs, unnecessary antibiotics, and then probably that we tried to prove it with matching up data from primary care and secondary care, that the complexities of NHS recodes and different ways of coding make it very difficult. But probably lack of finding out whether they're venous or arterial was leading to late referral to vascular. So the key intervention that we really needed to do to address what matters to patients but to heal quickly was an ABPI. So our learning was that really we couldn't impose this on primary care. So if we'd gone to primary care and said, what you really need to do, why are you doing ABPI? You really need to be doing it. Do it, it takes 30 minutes. I guess they would have turned around and said, you're asking us to do an extra thing, it takes 30 minutes, where's the funding for this? We haven't got time for this. So our learning was that we really had to work with users for them to understand what was happening, come along the journey with us, telling them the patient stories and the audit findings, and really asking them to design the improvements for themselves. And I guess part of this was really getting them to see that, well, actually, if you take 30 minutes up front, you will save 9 months down the line. And then we found that it's not just talking to nurses. We had to talk to everyone who is finding out everyone else in the system who could help them with their nurse timetable. So the GPs, practice managers, those are the people who can facilitate the nurses having time up front. But they all had to see that time up front meant less workload downstream, and particularly the patient stories and the audit was helpful for that. The nurses also designed a template, so there wasn't continuity of person, there was a different nurse every week, but actually if there was a template, so there was a continuity of record, the nurses would all know what had happened the week before and whether the patient needed an API that week, and if the wound was going on for longer than 3 months, well, then they should be reviewed again. So this is trying to draw a system diagram of what's happening really. So on the right-hand side is what was happening before we made our improvements. And the key intervention is at the intersection of the large circle and the smaller circle. That's getting the ABPI done at the right time. But previously it wasn't getting done, the wound wasn't healing, therefore there was a quick fix which was taking a swab, and they repeated that, another quick fix to take a swab, another quick fix to take a swab, because it only takes seconds to take a swab. And the consequence of this is 56 weeks, over a year average heal rate. But if we go to the larger green circle, if you do the right intervention at the right time and put patients, identify the 80% that is venous and put them into the right compression bandaging, then 80% will heal within 12 weeks. And we implemented this in a sort of a few friendly practices, and we audited it and found that we could reduce nurse appointments by 21 appointments per week and reduce nurse sessions down to 9 per week or experience weekend. And so this was direct workload reduction for those working, as well as improved patient care and reduced downstream consequences for the healthcare system. And the cost of that both to patients and in money terms. So I guess, so we really found that our solutions are very different whether we look outside in or inside out. So if we carried on looking outside, if we carried on looking inside out about how we were working as our particular organisation, then we would have scaled it down, done the same thing, but just more cheaply and more efficiently, but still the wounds would have taken a year to heal, and we'll be doing bad care, but just cheaper and more efficiently. But looking outside in, and we're all working together to find a solution to do what matters to patients, we actually, that is a problem more of effectiveness and increasing effectiveness rather than efficiency. And then we found, which we've always found with any of the improvement projects we've done around testing, that if you about. And also, this slide is something about the fact that we've always also found that it's an iterative process. So once we've tried to, so I guess the first piece of work was looking at making things effective for 80% of patients. But then once we've done that, we can start to study the 20% which are more complex. So these are the patients where they'll never heal within 3 months, and they'll always have very, very chronic wounds for lots and lots of different reasons, probably multi-morbidity. And so we identified that these really need more biopsychosocial input. So these patients are getting very depressed,